a surface. Okay, you have a surface for resuscitation. So ideally, you're supposed to have a resuscitator where you're going to resuscitate this baby, and you need a conducive room that is warm enough. So now I'm actually talking about the preparation before the baby is born. So the room needs to be warm. How are you going to tell that this particular room is ideal for the baby? So it starts with the labor room where you're nursing this mom, because it's also going to affect the outcome of this neonate. So it should be warm enough. And for the environment, we're looking at the temperature between 22 and 28 degrees Celsius. So all the delivery rooms and neonatal units are supposed to have the wall thermometer so that you can be able to maintain the temperatures. So one particular place where there's a problem when it comes to maintaining of temperature is in the theaters. You find that the aircon will be running, and you'll end up having a baby that is cold. So take note that this baby needs to be maintained at a normal temperature, and the temperature that we're looking at is 36.5 to 37.5. Okay, because we understand that this baby is going to lose heat through various processes like evaporation, conduction, convection, and radiation. So we don't want this baby to be cold. Okay. Then with regards to the equipment, there are a number of things that would require. So if you look at this, we've got the bags. This is a bag, okay, for resuscitating. And some most important thing during resuscitation, we've got different sizes. We have the smaller one. This is for the preterm units, and then we've got a bigger one, which is for the term units. The other thing that we need, will require a stethoscope, which is here. We'll need needles and syringes for resuscitation. Then we also have the penguin sucker. We have the suction catheters. Then here we have different sizes of masks for resuscitation. They are in sizes, okay? Then we also need to have the baby layette. You need to have the headgear. You need to have the socks ready. You need to have the towels to dry the babies. Then for infection prevention, remember one of the causes of neonatal mortality is actually sepsis. So we should take care of that. Okay, so you need to actually use the hand sanitizer. Okay. So if you don't have the hand sanitizer, I mean, you've got water and the soap, which you can use. So make sure you use that so that we can prevent the transmission of infection. Then we also have the gloves, which are very important. Then you also need to test the equipment. Things like the laryngoscope. Check. Is it working? Are you able to see the light coming out from there? Then we also have the strapping, and then we also need the drugs. So we have the adrenaline here, and you have to prepare the adrenaline. So we'll talk about adrenaline in a short while. Then we can also have a pulse oximeter here as you are checking. Then there we've got our CPAP tubing and the CPAP bottle. In case after resuscitation, this baby requires CPAP, you can easily put the baby onto CPAP. We also have the source of oxygen right here. We have a cylinder with oxygen, and we've checked that it's working. You also need the suctioning machine ready. You know, during resuscitation, that is not the time for you to start now running around to look for equipment. Make sure the equipment is clean, it's working, and it's ready for any resuscitation that you may have. Okay, so remember I've forgotten anything? Okay, I think I've mentioned everything. So I've used the hand sanitizer, and now I'm going to put on the gloves because I'm going to demonstrate. Kabelu is here with me. We're going to demonstrate together. He's already used the hand gel as well, and we'll put on the gloves. So, so that we can show you the steps. So when the baby is born, you're not going to resuscitate all the babies. There are those babies that require resuscitation. Okay, so it means you need to prepare in advance, you need to assign the roles, you need to speak to the mom, and if you're anticipating any bad outcome, that probably this is a baby who's in fetal, who has got fetal distress, and you know that you may want to resuscitate this baby, you need to actually inform the mom in good time. Then we also need a timer, which is very important. You need to time your resuscitation. For how long are you going to resuscitate this baby? It's very important because you can't stand in and resuscitate the baby for an hour or for 2 hours, then probably wouldn't know what you're doing. Okay. So, yeah, so I will go now straight into a baby. So this afternoon, we're only going to look at the baby that requires resuscitation. Remember on the algorithm that I showed you, there are colors, and those colors mean something. There's a green there. You know that if the baby is breathing, goes into green, you're going to give routine care to this mom. You give it to the mom. You're going to do skin-to-skin care, initiate breastfeeding, and continue with the routine care. But again, there's also some red color on the algorithm. I believe everyone got a copy of the algorithm. Or Dr. Nabdiato, you can actually share on the group so that people can actually get the algorithm. Okay, so there are those babies that are in red. Those babies that are in red is they need help. So you need to resuscitate them. So when the baby is born and is not breathing, so one, because we're doing skin-to-skin care immediately the baby is born, the baby is delivered onto the mom's abdomen. But if that baby is not breathing, you're not going to continue with your delayed cord clamping. You're going to cut the cord long enough and you are allowed to milk the cord, okay? So that, because now resuscitation takes precedence over your delayed cord clamping. So you quickly move this baby onto a warm resuscitator. You need to realize that you need help because this is a team effort. So you're going to call in for help, okay? Because you can't resuscitate alone, and because you had already assigned some roles to your team members, then you're going to call in for help and you need to set time. So when we're saying you set time, for how long are you going to resuscitate this neonate? You remember, it's 20 minutes resuscitation. It doesn't mean that when you're resuscitating the baby starts to pink up, the heart rate is increasing. Just because it's at 20 minutes, you're going to stop your resuscitation. It doesn't mean like that. So if the baby has responded to your resuscitation, is pinking up, the heart rate is improving, you will continue with the resuscitation. But if you have done all the steps correctly, and this is a baby who's still not pinking up, not responding to your resuscitation, then probably after 20 minutes, you may need to call off the resuscitation, and you have to do it as a team. You find out from the team members, should we go ahead with the resuscitation or should we stop? And you agree as a team that probably the baby has failed to respond to the resuscitation and you're going to call off the resuscitation.
Recording in progress.
Okay. And in resuscitating the baby, the most important thing that we're going to look at is the golden minute. We always talk about the golden minute, but do we understand when we say a golden minute? Okay, so our resuscitation should be very fast because this is the baby who's holding the breath, okay? So in that 1 minute, the reason why it's called a golden minute, you have to give a breath to this neonate. That's how fast you should be. And that's what explains the emergency preparedness. You have to prepare so that you can quickly give a breath to this patient, okay? So we've cut the cord, we've moved the baby to a surface for resuscitation. We're using a surface for resuscitation. Ideally, you're supposed to have a resuscitator, but it doesn't mean that when you don't have a resuscitator, you can't resuscitate a neonate. All you need is a surface for resuscitation, okay? So the first thing that you're going to do when you get the baby, remember you can have 2 categories of babies. You have the preterm and the term neonates. For the term neonates, the first thing that you're going to do is to dry and stimulate the baby. For the preterms less than 1.5, you're going to wrap them in a plastic. So on our preparatory table here, we have the plastic which is here. So the plastic that we're using, usually it's a food grade plastic. You know that nice soft plastic you get from the supermarket. It's soft and it's usually used when you're covering the food. That is the plastic that you're going to look at. Don't just pick any plastics from elsewhere and cover the baby, okay? So those that are 10, like 1.5 and above, we'll start with the drying, okay? So this is what you do, dry. As you're drying the baby, you're also stimulating the baby, okay? So in doing this, you may find that this is a baby that may actually cry. After you dry and stimulate the baby, you're going to remove the wet towel, okay? And then you're going to cover this baby in a dry towel. Make sure you cover the baby in a dry towel because you want to maintain the normal temperature. You're going to put the headgear on the baby, and then you're also going to put the socks. Mr. K, you can put the socks on the baby. So you also put the socks onto the baby, okay? So once you do that, this is a baby that may cry after just drying and stimulating the baby, okay? So you're going to do your initial assessment. From now up to the end, I'll be talking about assessing a baby, and we're going to use 4 things that we're going to assess the baby for. So we're going to look at the color of the baby. Is the baby pink or is the baby blue? Okay, you'll be worried if you have a blue baby, okay? Then if the trunk is pink, but the peripherals are slightly blue, you're not going to get so much worried because in a short period of time, this baby will pink up, okay? But if the baby's peripherals are also blue, then that is something that you need to be concerned about. So that's color. Then you're not going to look at the tone. The normal tone for the baby is a flexed position. This baby needs to be in a flexed position. Remember, even when the baby is in utero, it's in that flexed position. And so you're going to check this baby. How is the tone of the baby? Is the baby flexed or is the baby floppy? Okay? Breathing. You need to see the rise and falling of the chest. So you're going to visibly see on the chest. That's why you're leaving part of the chest so that you can assess the breathing of the baby. Okay? Then the heart rate. What are the ways that you're going to assess the heart rate? See, you're going to check with the stethoscope. Okay? The other thing that you can use as a pulse oximeter, but remember a pulse oximeter has got also limitations. If the baby is cold, it may not give you something accurate. Make sure that the baby is warm, okay? And it gives that delay. You need to look at the place of, that is going to show there. So that is just a delay that shows with the pulse oximeter, but that's what you can use. Or you can use the ECG machine, okay? You cannot feel for the pulsating cord, okay? So don't go and check because that cord has been cut, and if you go and use the cord, you may just be feeding your own pulse, okay? Even when the baby is not breathing or the baby's heart rate is not there, you may feel that there's some pulse if you use your fingers to check, okay? So after you assess, you realize that this is a baby who's not breathing or the baby is gasping. Okay, there's a question.
Thank you so much, Sister Jean. Such an elaborate explanation. Team, so far, if there are any questions, just feel free. You can raise your hand or you can post something in the chat box. We don't want to leave you behind. So I've just interrupted Sister Jean. I know she has a lot to share, and you can tell from how she's flowing. So I really want you to get engaged. This is an interactive session. So we want you to get engaged and ask any questions so far. So I can see Mukanta Sinta has a question to ask. So you can unmute yourself and go ahead.
Good afternoon, Tim.
Good afternoon, thank you.
All right, my question is on the point where the matama said that after you get the baby and then you put on the resuscitation surface, you start with the drying and wiping and also stimulation. So now in the point where you don't know if the baby has maybe meconium in the throat, and then you start wiping and drying first, meaning the baby will be shocked. So I want a clarity on that.
Thank you so much. We can get another question if there is anyone else who would like to get some clarity. We can get 2 more questions if there's anybody else who would want to get more clarity. I can see something in the chat box. We'll look at the chat box and just ask if there's any other burning question. We'll ask you to just unmute yourself and go ahead. Okay, I'll allow Sister Jean to respond to that question. Sister Jean.
Okay, so if I got your question clearly, you were asking about the baby that has aspirated meconium. So the reason why I'm even, when I'm drawing and stimulating the baby, I'm actually also assessing. So you're looking in the mouth. If you see that there's plenty of meconium, it's copious, you know, we are doing it, the two of us. My partner here can quickly suction, okay? But with meconium, if the baby has aspirated meconium, you may even have a history that this is a baby that was born through meconium, and you are saying, no, you can't start anything. You're going to just hold the baby until you suction. Remember, meconium aspiration, it means the meconium has gone below the level of the vocal cords. So the damage has already been made. So you cannot go with that suctioning machine, a suction catheter all the way up to the lungs and suction out that meconium. What you will do is post-resuscitation care, you're going to resuscitate. What the baby requires now is just the ventilation. You're going to ventilate this baby. And probably if it's meconium aspiration, you can also give surfactant, which is rescue surfactant. Okay.
I hope the question has been answered. Mukanta Center, if you are comfortable with the answer, please kindly indicate.
So we'll further talk about it as we go down, so you'll be able to understand.
I think the question is coming in because our practice has been, if there is meconium stained, we face suction. But the rule now is that you cannot suction what you cannot see. So we'll actually talk about meconium aspiration or meconium stain as we go through the preparations for the resuscitation. I think you'll get it when we do the practical part.
Okay, so we can continue.
Please go ahead.
Okay, so this is a baby who's not breathing. The first thing we're going to do is to put the baby in neutral position. Why are we putting this baby in neutral position? Remember, this baby is born with big head and big tongue, so the airway is the closest. So you may even want to put a rod drape under the shoulder so that you put the baby in neutral position. If you flex the neck, it closes the airway. If you hyperextend the neck, again, the air will close. So you're going just to put the baby in line. Okay. Thank you. So he's put the rod drape under the shoulder. Okay. Okay. So we've already assessed. So now we need to find which one is the appropriate size of the mask. Just pass me the mask. Give me the big one as well. Okay. So the masks, you're not going to waste time looking at the size and trying to read the signs. The appropriate mask is the one that covers the mouth and the nose. So is this mask able to cover the mouth and the nose? So you're going to go below the lip up to the bridge of the nose. If it covers the nose and the mouth up to that, then this is the appropriate mask. But if you get a very big one, and then it goes all the way up to the eyes, that is not the right size of the mask, because you want to create a tight seal, and you won't be able to create a tight seal. Again, if you are putting on the eyes, this baby, it stimulates the vagus nerve, and then you have the heart rate dropping. Okay, so it means you'll be working against yourself. So picking the right size of the mask is very, very important, and you just roll it over. Then you get your bag, because you've tested your bag is working, and then you're going to mount it to the bag. Okay, fix it like you mean it, okay? So that during resuscitation, it doesn't come out. So as you can see, I haven't even connected to oxygen, because room air has got 21% of oxygen, and that may be okay to revive this baby, okay? So when you get, again, you're going to roll over the mask up to the bridge of the nose. Then you're going to use your C, okay? The C goes on top of the mask, okay? Because you want to create a tight seal. And then the third finger will go and touch the jaw, which is the bony part. Do not push your fingers like that, okay? It's the C, the E, it's the jaw part, and that acts like your pivot. You can see that I'm able to push the baby into neutral position with the third finger. Then the 3 fingers here supports the head, as you can see. So this makes the E grip, and this is the C grip. So because we want to create a tight seal so that when we give a breath to this baby, it's going to be effective. In the past, they used to tell us that the first step is to suction. Like Mr. Cavalier said, you can't suction what you can't see. There's no logic in going to suction the saliva in this baby. So if there's nothing that you can see in the mouth, don't waste your time, because this is the baby that is holding the breath. You just need to go ahead and give a breath. Okay. So what kind of breaths are you going to give? The first breaths you're going to give are the 5 inflation breaths. Okay. So what are inflation breaths? I said we'll be explaining this as we go on. So the 5 inflation breaths, these are sustained breaths, each of the breaths lasting 2 to 3 seconds. And while you're giving a sustained breath, remember in utero, the lungs are filled with a fluid. So when the baby is born and the baby does not cry, it means there may be some fluids in this baby. The lungs may be wet, and what you want to do is to push out the remaining fluids from the lungs. Okay? So I'll demonstrate the inflation breaths. You need to pay particular attention because you need to differentiate it from the ventilation breath. So you're going to give, and we're going to sing this little song like Hubbly Bubbly. That's what we're going to use, because that was timed and it was giving about 2 to 3 seconds. So it will be 1 Hubbly Bubbly, 2 Hubbly Bubbly, 3 Hubbly Bubbly, 4 Hubbly Bubbly, 5 Hubbly Bubbly. So you're giving the 5 inflation breaths. And when you're giving the inflation breaths, you should be able to see, is the chest rising or not? If the chest is not rising, then there's a problem. The airway may be blocked. So what are you going to do if the chest is not rising? There are 3 airway maneuvers that you're going to use. This patient is already in a good position, neutral position. The seal is properly done, so we're going to do the maneuvers. So if the history says this is a baby that was born through meconium, your first suspicion will be maybe there's a meconium plug. Okay. So if there's a meconium plug, you need to suction it out, and you can't do it blindly. So you're going to use a laryngoscope. So this one will be suctioned under direct light. Okay. Under visualization. So this is a laryngoscope. Remember, you're not intubating, and you're going to hold the laryngoscope in your left hand. Okay. So you're going to open, it's just assisting you with the light. Bear in mind that I'm only dealing with one baby. I'm moving from one baby to the other because I need to show you other babies, we cannot use them for certain maneuvers. Okay, so when you open and you check, it's not against suctioning, it has to be logical. So if you see that there's a plug there, it can be a meconium plug, it can be vernix, and it can also be a blood clot. If it's there, you cannot use a penguin sucker because a penguin sucker will just reach the mouth. So you need a suction catheter, connect it to the suction machine, and then you go in and then yank out whatever is in there. Okay. So that is the first maneuver. You don't need to do all the maneuvers. That's why it's important to listen to the history of how this baby was born. If it was in meconium, that is your first suspicion. Okay. The other reason why the baby's airway may be closed could be the tongue which has fallen back. Remember, a baby that has been born flat, there's loss of the pharyngeal tone. So the tongue is defaults back and closes the airway. So what are you going to do about that? Okay, to create a patent airway. So you're going to use, there are 2 maneuvers that you're going to use. So the first one we're going to do is a 2 persons airway maneuver or a jaw thrust. You're going to use your thumbs, put on the cheekbones or the maxilla, okay? Then you're going to lift the jaw, not lifting the neck, okay? Okay, so I push, then I pull at the same time, it's simultaneously, okay? And you're going to lift like that, okay?
Over.
Okay, then I move my thumbs on top,
then I'll give the 5 inflation rates. 1 hubbly bubbly, 2 hubbly bubbly, 3 hubbly bubbly, 4 hubbly bubbly, 5 hubbly bubbly.
Thank you. Okay. So that is a jaw thrust or a 2 persons airway maneuver. Okay. So, but if I'm holding like that, it means that if I let go of the jaw, it goes back into its position. So there's another maneuver that you can do apart from jaw thrust, which is the third one, insertion of an oropharyngeal airway. Okay. So this is an oropharyngeal airway. Okay. We have them in different sizes. So you need to pick the appropriate size. How do you know that it's the right size of the oropharyngeal airway? You're going to measure. Okay, let me just open here so that you can see. So the landmarks are mid-upper lip to the angle of the jaw. Okay, then you know that it's the right size of the mass of the oropharyngeal airway. We've also got this one, which is actually very small. Okay, this one, mid-upper lip to the angle of the jaw, it's not even reaching the angle of the jaw, so it's smaller. In adults, you actually go in like that, then you twist it to put it. But in neonate, just depress the tongue, okay? So, or use any tongue depressor. It can be a penguin sucker, the tip of the penguin sucker. You can use a laryngoscope. You can use even just a spatula, which is a tongue depressor, but the best during resuscitation is just your thumb. So depress the tongue and then you insert it the way, you don't need to twist it, just insert it like that. And then you can connect and give your inflation breaths. Remember, you can't jump this step of inflation breaths. If you haven't given the inflation breaths, you can't go to the next stage until you have a patent airway and you're able to give the inflation breath successfully. Okay, so we've given the inflation breath successfully. And remember, in between, you need to continue bagging even when you are assessing the baby. So we've given the 5 inflation breaths, and now we're going to assess. What are we assessing for? Again, you look at the color. How's the tone? Is the baby breathing? Check for the heart rate. Okay. So
Heart rate is slow.
okay, the heart rate is slow. So what next can we do? Then we're going to give ventilation breaths. So how many ventilation breaths are we going to give? We're going to give 15 ventilation breaths in 30 seconds. How are we going to manage that? Again, we're going to use the Mississippi. So we'll say 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi, 6 Mississippi, 7 Mississippi, 8 Mississippi, 9 Mississippi, 10 Mississippi, 11 Mississippi, 12 Mississippi, 13 Mississippi, 14 Mississippi, 15 Mississippi. You had seen the way I was bagging, just enough to raise the chest. I was not bagging like this because some people would bag like that and it's making noise. That is not right. Because if ventilation breaths, it's like you're mimicking the normal breathing of the baby. So you're giving them a little bit faster as compared to the ventilation, to the inflation breaths, because these are taking 1 to 2 seconds. That's why they're a little bit faster. But the chest should be able to rise. As you can see, the chest is rising. Okay. So we've done our assessment. Again, check the color, how's the tone, is the baby breathing, the heart rate, again, you check. If it's still very slow, remember, don't ever forget about the sugar, okay? So you need to check the glucose in this baby, okay? The normal blood sugar is 2.6 to 7.0. So you'd ask you can ask your partner to check the blood sugar. If the blood sugar is less than 2.6, know that this is a baby that is going to require the 10% dextrose, okay? So how much 10% dextrose are you going to give and through which route? So you are going to give it at 3 to 5 mils per kg of 10% dextrose, okay? That's a bolus you're going to give. So by which route? You cannot give it rectally, like it's a common practice in some institutions. So you have to give it intravenously, okay? So if you are unable to insert a peripheral catheter, you can insert an umbilical vein catheter, the UVC. So when you look at the cord, it has got 3 vessels, 2 are the arteries, and then there's a bigger vessel, which is the vein. You can push in a UVC there and give your 10% dextrose, okay? So we've checked, we've done the ventilation breaths, and now this is a baby who hasn't responded. Probably the heart rate is still very slow, he's still gasping, and now we have to do chest compression. So this is the point we now need to do the chest compressions. And when you reach the chest compression, you need to connect to oxygen. So kindly connect to oxygen. Remember, these bags have got a port where you can connect oxygen. So you turn the oxygen on there and connect to the bag. So that's a port, okay? That's a port showing there. And you connect this bag to that port so that you can give supplemental oxygen. So if you've got a pulse oximeter, that can even guide you. You may even start it earlier than that, depending on the saturations of oxygen that you are giving. So this is done by 2 people. So we're going to demonstrate it with Kabelu on how to do it. So he's going to show us the landmarks. Please show us the landmarks.
So when we are doing the chest compressions, there are landmarks that we follow. We don't just go to do the chest compression. We might be doing the chest compression on the wrong landmarks. So we have the 2 nipples. So you draw an imaginary line on the 2 nipples. Then at the middle, you go just 2 centimeters below the imaginary line that you've drawn on the 2 nipples in a neonate. That's where you are going to place your 2 thumbs. So I'm saying there are 2 nipples. Fortunately, this one is broken. So if there's one here, another one is, so you draw an imaginary line, then 2 centimeters below, that's where you place your 2 thumbs as you do your chest compressions. Then the rest of the fingers, you hold the baby like that. So the ratio is 3:1. I'll give 3 chest compressions, should give 1 ventilator breath. That's the ratio. And it should be coordinating. We'll show you how we are going to coordinate. It doesn't matter who starts. I can start with the 3 chest compression, then she gives the ventilator breath. So we can start. So the imaginary line.
Before we start, the other one is a 2-finger technique. He has just shown you the thumb technique. We have also the 2-finger technique. So the depth is 1/3 of the AP diameter, anterior-posterior diameter. That's how deep you need to go in. Because if you just do like that, it may not be effective. Remember, the heart rate is very slow. So when you put your, on the same points that he has explained, okay, you're going to go in deep with the 2 fingers. That means the other hand should be able to support it to be 1 in, 2 in, 3 in. That's how deep it should be. So this helps, especially if you want to put up a UVC, you give room and chance for the other person putting up an umbilical vein catheter. So let's do this in 30 seconds. We'll see how we're going to do it.
So imaginary line, then 2 centimeters below. Now go 1 in, 2 in, 3 in.
1,
1 in, 2 in, 3 in.
2,
1 in, 2 in, 3 in.
3,
1 in, 2 in, 3 in.
4,
1 in, 2 in, 3 in.
5,
1 in, 2 in, 3 in.
6,
1 in, 2 in, 3 in.
7,
1 in, 2 in, 3 in.
8,
1 in, 2 in, 3 in.
9,
1 in, 2 in, 3 in.
10,
1 in, 2 in, 3 in.
13,
1 in, 2 in, 3 in.
14,
1 in, 2 in, 3 in.
15. Okay. So you could see how we are coordinating. So we're giving 1 breath to 3 chest compressions, and we give that in 30 seconds. Okay. So it means if I'm giving 1 breath, I would have given 15 breaths, and he gave 45, around 45 chest compressions. Okay. So you continue doing that. Then you still come back to assessment, reassess. How is the color? The tone of the baby? Is the baby breathing? How's the heart rate? Remember, you're only going to do the chest compressions if your heart rate is
Slow.
less than 60. And it says it's very slow. So this is the point that now we're going to give adrenaline. You don't start with adrenaline. So adrenaline comes, start with adrenaline. Okay. So this is adrenaline. Adrenaline comes in an ampule, and when you read, it's 1 in 1,000. That is the strength of adrenaline. So 1 in 1,000, you need to change it to 1 in 10,000 because this is the requirement of the baby. Okay. But you have to read the prescription of that because there's also an adrenaline that comes in as 1 in 10,000 already diluted. So, but what we have right now is 1 in 1,000. So you're going to get that 1 ml of adrenaline, and then you mix it, you get your syringe with water for injection, which is 9 ml of water for injection. Add the 1 ml of adrenaline, you would have made 1 in 10,000 of adrenaline. And on the syringe, you're going to label it as adrenaline 1 in 10,000, date of dilution, time of dilution, because after 24 hours, you need to discard that preparation. Okay. So that's what you do. I hope that is clear on the dilution of adrenaline. And then how much are you going to give adrenaline? So you give, the dosage is 0.2 ml per kg. Okay, that is the initial dosage. So you're going, if the baby is 3 kilos, you're going to give 0.2 multiplied by 3 kilos for that baby. Okay, that's how much you're going to withdraw from there. And when you're giving adrenaline, you're going to use a closed loop communication like we discussed. Closed loop communication is, I ask for adrenaline. So the person, because I'm initiating a message, so the sender should be able to acknowledge that message, okay? They will be able to ask, did you say I should give this particular drug with maybe 3 ml of this adrenaline? They should be able to repeat that message so that you can prevent errors, okay, in resuscitation, because most of the errors will happen during resuscitation. I may say I need 3 ml, somebody will bring 9 ml, okay, or 30 ml. Then we could have caused harm to this baby. Then even after they give adrenaline, because you remember resuscitation is so stressful, they may get stressed up and then they need to confirm that they've given adrenaline, okay? So can we do this? Can Kabelu give adrenaline 0.6 ml?
Well, Sister Jean, you said I gave adrenaline 0.6 ml or units.
Okay.
Let me go and prepare.
Okay. So he's actually acknowledged it and is ready to prepare, and then he will prepare. When he comes and gives, he should be able to confirm that he
Did you say I give 0.6 ml of adrenaline?
Yes, I did.
Okay. 0.6 ml of adrenaline given to our baby.
Thank you.
Thank you, Mr. Kabelo, for giving that adrenaline. And indeed, network, I hope we are following closely. This is a very important session and we're picking up a lot of things. I've seen a number of questions that are in the chat box, and thanks, Dr. Kapembwa, for responding to most of these. But Dr. Kapembwa, I'll give you the floor in case you want to make a comment or two with regards to the resuscitation and how far we've gone in our demonstration. Dr. Kapembwa, are you on the call?
Yes, I am. Apparently, you were not allowing to me unmute. Yes, I'm on the call. I think it's going well. I think let's proceed. Then we'll continue polishing up. I think it's important for people to bear in mind that this simple algorithm is specific for low resource settings like ours. That's why you find that it's very simple and people are not looking at the saturations because they're not, they don't have a pulse oximeter. The heart rate is being done in that crude way. I think this is just the background I want to give. We can continue.
Thank you so much, Dr. Kapembwa. Sister Jenny, you can continue.
Okay, thank you. So you've given adrenaline, and at that point when you give adrenaline, you should not stop chest compressions. Remember, the heart rate is very slow in this phase. Okay, so after your adrenaline, you remember the initial one is 0.2 mils per kg. So as you continue and reassess, you realize that the heart rate is still less than 60. You're going to give a second dose of adrenaline, and now you still give it at 0.2. Okay, so the initial one is 0.2 per kg, and the second dose of adrenaline is also 0.2 mils per kg. So you can give it 3 to 5 minutes after the initial dosage. Okay. So you realize if you look at the algorithm, we are going towards 20 minutes, and we should be making decisions. Are we making progress with this baby? Have we done everything that the baby requires? And remember, on the same algorithm, there's a normal saline. When do you give the normal saline? Okay, so normal saline is not routinely given. You only give it if there was any blood loss in the mom or even in the baby. So was there any antepartum hemorrhage? Then go ahead and give your bolus of normal saline while you're waiting for blood to transfuse in this baby. Okay, so it's not routinely given. Okay. Then once you are almost going, even as you are doing resuscitation, depending on how many you are, it's very important that one of the team members will actually speak to the mother. Remember, this baby belongs to a particular family. So you need to explain. They are very important when it comes to resuscitation, and you shouldn't tell them any lies. You have to be truthful. So you need to explain. Somebody else needs to go and sit with them, explain what is going, and then after that counseling, or if at the end of your resuscitation, you can go and sit with them and then tell them what is happening to this baby. Then as a team, you need to decide, are you going to transfer this neonate? Has the baby done very well? If the baby has done very well, has responded to your treatment, and you want to take to your neonatal unit, there now comes where you have to, probably we had already set for CPAP, you may want to put the baby on CPAP, you stabilize the baby, and before you transfer, you are going to use the SBAR. Like I mentioned when we started that we have to use SBAR. SBAR. What does SBAR stands for? It's situation, background, assessment, and recommendation. So the S stands for situation, B is background, A is assessment, and R is recommendation. Why are we using this communication? Remember, where you are taking this baby to, they're also busy. So if you keep on telling a lot of stories, this person is like, come on, get to the point. So this is internationally recognized, and because you need to give information, accurate and concise information. So you're going to say situation, like for instance, I have a term neonate that is not breathing. So that is my situation. So what led to that situation? That is what we call background. So it could be this is a baby that was born through meconium due to prolonged second stage of labor, okay? So, and then your assessment. What can you see on this baby? The color is pink, probably. Okay, the saturation is at 88. Those are your assessments. So you're talking about the vitals, okay? Then recommendation. Why do you have to give a recommendation? Because when you're going, let's say, if this is a baby that requires mechanical ventilation, you're actually going to tell them to prepare for mechanical ventilation so that will not interrupt the management of the patient. So you're going to reach with this baby, and quickly the baby will be moved onto the ventilator. So there won't be any delays. Remember, it gets time to prepare for these things. If it's a CPAP, you've started your bubble CPAP. You need to tell them so that they prepare for this baby and they'll know where to put this baby. Yeah. Then after all is done, your resuscitation, the baby has been transferred, you need to discuss with the team. before you even discuss, you need to document. Documentation is very important. If you don't document what you were doing during the resuscitation, then you haven't done anything. Nothing has been done. So document when you started the resuscitation, who was involved in the resuscitations, what exactly did you do? Did you give any drugs? At what time did you give? And you need to sign that referral. Who was there? So you put your names down there before you take. Then afterwards, you're going to actually agree with the team and say, did we do the resuscitation very well? Did we follow all the laid down steps that we have? And then, so that for the next case that you may have, you may improve. Look at the equipment that you had. Did it work very well? Does biomedical department need to look at some of the equipment? Those are the things that you need to discuss. Then prepare for another resuscitation in case you have the resuscitation. Okay. So unless there are questions, we just move to the last part, which is a simulation, which we're going to act out.
Just to add on something, on the algorithm, it's saying maintain normal temperature. So we need to know the normal temperature in a neonate. So a normal temperature in a neonate is about 36.5 to 37.5. If we know that normal temperature in a neonate, then we are going to maintain a normal temperature in a neonate. How do you maintain a normal temperature in a neonate? One, we've talked about it. A baby who is less than 1.5, we cover that baby into a plastic. That's maintaining the normal temperature. We've talked about the delivery room temperature, which is about 34 to 37 degrees Celsius. That is how we maintain a temperature in a delivery room. So all those measures, including the famous kangaroo mother care that we're doing, we're just maintaining the temperature in this unit. Remember, hypothermia also kills. That's why we're talking about maintaining a temperature throughout our resuscitation. Yes.
Thank you for that. So just reminded that I didn't mention the dosage for normal saline. So you can give 10 to 20 mils per kg, bolus of normal saline. Okay.
Thank you so much, Sister Jean and the team. So as they are getting prepared to give us a simulation, if there's any question, please feel free to ask your question. You can unmute yourself and ask. We have a panel of experts to help us answer those questions. So as the team is getting ready, feel free to ask any burning questions so far. I know most of the questions have been handled in the chat box. If there's any other question not yet answered, kindly unmute yourself and ask your question.
We are going to like mimic like a real life situation. Probably this is a baby who's not breathing. So we'll have the team here to act out. So we'll take like a baby has been born through meconium, okay? It's in the labor ward, we're in the labor ward, and now we're going to act out like it's real. This is a baby that is born not breathing. How are we going to handle this baby? If need be, how are we going to move this baby? That's what we're going to do. Okay, okay, you can just walk and see what we're going to do. Okay, so team, good morning.
Good morning, how are you?
Okay, so it's a good morning. I think it's not busy now. We need to prepare for resuscitation. In case there's a problem, I will lead the team. Okay, for this shift, I'm going to lead the team, and I think we will assign some roles. Kevin, would you mind doing the chest compressions like my immediate helper in case there's a resuscitation, so you can do that. And you can handle the phone issues if need be to make phone calls. Okay, Humphrey? How are you? Okay, so would you mind doing the documentation? You know, it's very important, like timekeeping and making sure that we're on point. You need to really time us and give us prompt if we need that. Okay, so you have everything to use for your timing. Okay. Okay, so you also check for us if the temperature is okay. Make sure that the room is warm enough for the baby. Okay. So Matthews, would you mind, you okay today?
I'm very fine.
Okay, great. So would you mind giving the drugs? You take care of the circulation. So if we need a UVC line, you are going to put up the UVC line. You're going to give, should we need 10% dextrose? If we need adrenaline, you're going to take care of that. Okay, so can we all now look at our equipment? Do we have anything? Let's put everything in place. Let's make sure that oxygen is there. And remember, we need to use the hand sanitizer, which is there in case we have anything. Okay?
We have most of the things. Okay. Check expiry dates.
So now the baby is born and is not breathing. We have a baby, guys. Here we have a baby and it needs your help. You need to grab up.
Okay.
Okay. This is the baby is already delivered and somebody has already cut the cord and quickly moved to the resuscitator. We need to resuscitate. This is a baby who's not breathing. Okay. Have a look, please get closer. Okay. So I'm looking at the color. How's the color?
Blue.
Have a look.
Color is blue.
How is the tone okay? How's the tone?
Tone is floppy.
Okay. Is the baby breathing?
Baby is not breathing.
Okay, check for me the heart rate. Oh,
Less than 60.
it's very slow. Just put on the soft, please. Put the baby in neutral position. Pass me the band, please, and a mask. That's an appropriate one.
Good.
The right one. Okay. One, have the bubbly. Two, have the bubbly. Three, have the bubbly. Is the chest rising?
The chest is not rising.
Oh, this is a baby that was born through meconium. Let's check the airway. Give me the laryngoscope, please.
There you go.
Okay, suction catheter connected to the suction machine. Okay,
Connected to the suction machine.
okay.
Switch it on.
Ah, can you see anything?
The meconium plug.
Oh, there it is. Okay, I've removed it. Thank you. Okay, let's try to give the inflation breaths again. One, have the bubbly. Two, have the bubbly. Is
The chest is
rising?
not rising.
The chest is not rising. Probably the tongue has fallen back. Give me the oropharyngeal airway. Looks like an appropriate size. Okay. Okay, so we've inserted. Okay, it's already inserted. One, have the bubbly. Is the chest rising?
The chest is rising.
Okay, two, have the bubbly. Three, have the bubbly. Four, have the bubbly. Five, have the bubbly. How's the color now?
Color is blue.
Okay, tone.
Lovely.
Is the baby breathing?
Baby is breathing. That's me.
How's the heart rate? Please cover the baby.
Heart rate is still low.
Okay, please cover the baby. Okay. One Mississippi, two Mississippi, three Mississippi, four Mississippi, five Mississippi, six Mississippi, seven Mississippi, eight Mississippi, nine Mississippi, 10 Mississippi, 11 Mississippi, 12 Mississippi, 13 Mississippi, 14 Mississippi, 15 Mississippi. How's the color now?
The color is pink on the trunk, the extremities.
Okay, and the tone?
The tone to floppy.
How's the heart rate? Check for me the heart rate. Still
Still
very
less than
slow.
60.
Okay, so would you mind us, let's do a chest compression. Matthews, can you do a blood sugar?
Humphrey, give us oxygen.
Okay,
1 in, 2 in, 3 in.
1,
1 in, 2 in, 3 in.
2,
1 in, 2 in, 3 in.
3,
1 in, 2 in, 3 in.
4,
1 in, 2 in, 3 in.
5,
1 in, 2 in, 3 in.
6.
1 in, 2 in, 3
Blood
in.
sugar, 7.
1 in, 2 in, 3 in.
Our sugar is at 3,
1 in, 2 in, 3 in.
8,
1 in, 2 in, 3 in.
9,
1 in, 2 in, 3 in.
10,
1 in, 2 in, 3 in.
11,
1 in, 2 in, 3 in.
12,
1 in, 2 in, 3 in.
13,
1 in, 2 in, 3 in.
14.
1 in, 2 in, 3 in.
How's the color now?
Color is pink, yeah.
The tone?
Tone,
Okay,
complexion.
continue chest compressions. Is the baby breathing?
Gasping.
Continue chest compressions, please. Okay.
1 in, 2 in, 3
Uh,
in.
Get the stethoscope and check for us the heart rate.
1 in, 2 in, 3 in.
1.
1 in, 2 in, 3 in.
Okay, the heart is still very slow. Okay. So, Matthews,
The system.
can you get adrenaline?
2 in, 3 in.
1 in 10,000, 0.6 mils.
1 in, 2 in, 3 in.
Yes.
said I get 2 in, 3 in. 1 in, 2 in, 3 in.
Come again?
Did you say I get adrenaline 0.6 mils?
Okay, so I said
3 in.
get adrenaline. This baby looks like a 3 kg. So let's take 0.2 mils per kg of adrenaline, 1 in 10,000, and give it intravenously. Okay?
1 in, 2 in,
Would you
3
want to
in.
repeat that?
1 in, 2 in, 3 in. 1 in, 2 in, 3 in. 1 in, 2 in, 3 in.
5,
1 in, 2 in, 3 in.
6,
1 in, 2 in, 3 in.
7,
1 in, 2 in, 3 in.
Sister Jean,
2
did you say I give 0.6 mils
1 in, 2 in, 3 in.
yes,
1 in, 2 in, 3 in.
7.
0.6 mils of adrenaline given?
Okay, thank you so much.
2 in, 3 in.
7,
1 in, 2 in, 3 in.
8,
1 in, 2 in, 3 in. 1 in, 2 in, 3 in.
10,
1 in, 2 in, 3 in.
11,
1 in, 2 in, 3 in.
12,
1 in, 2 in, 3 in.
13,
1 in, 2 in, 3 in. 1
14,
in, 2 in, 3 in.
15. Okay, let's check. How's the color now?
The color is pink.
Okay, it's picking up. How's the tone?
Tone, flex.
Okay. Is the baby breathing?
Baby is breathing.
Okay, how's the heart rate? Check for me the heart rate. Okay, the heart rate has improved. And this is the baby that is breathing now. So we'll have you.
5 minutes already, Tim.
Oh, thank you very much for the prompt. So please put this baby on we can use CPAP. Please put the baby on CPAP and Kabelu. Okay, so he can put on CPAP. Kabelu, you need to speak to the father. The father needs to know what is happening. Okay, so you need to explain what we have done. Please, you can take off your gloves and speak to the father before we transfer the baby to the neonatal unit.
Mother is around.
Oh, even the mother is around. Okay,
Yes.
please speak to the mother, please, and explain everything that we did.
Sister Jean, the baby is now on CPAP.
Thank you very much, Matthews. Okay,
Saturating of T.
you can connect the pulse oximeter, is there?
You can just face me. Good afternoon. I'm Kalomba, I'm a midwife. Change your baby.
And this is Banda.
So we've managed to deliver a baby. The baby was born through pneumonia. Pneumonia is the first pupil,
Okay,
and because the baby was distressed.
my baby fine.
For now, I can say we've done all the interventions. We've resuscitated the baby. Yeah, we've tried to help the baby to breathe. And what is happening now is the baby is, I can say the baby is improving. I'm not saying the baby is okay, the baby is improving because of the intervention that we've done. So we decided as a team to transfer your baby to neonatal intensive care unit where the baby will have all the comprehensive care now from our labor ward.
Thank you so much. Thank you so much. When can I hold my baby?
For now, the baby is on CPAP, but once the baby is stabilized, I think we'll go together so that you know where the neonatal intensive care is as we admit the baby in the neonatal intensive care unit.
Thank you so much.
Where is the father?
The father is at work.
Is aware that the baby has been born.
I'll give you a call.
Okay. Please do that.
Okay.
Any questions for us before we go to Nikki?
I just want to know when my baby will start feeding. Will I be able to hold my baby and feed my baby?
So for now, the baby is on what we call CPAP, that is machine. We are giving oxygen to the baby since the baby was deprived of oxygen during delivery. So we are giving oxygen through CPAP, and for now you can just see the baby and you hold the baby when the baby is stabilizing.
All right, thank you so much.
Okay.
So you've communicated to the mother. The baby is actually on CPAP now. So the next thing we need to plan for this baby to be transferred to the neonatal unit. So Kaberu, would you mind making a call again to the NICU so that we'll know if they are ready for this baby?
Ring, 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 ring. Hello. Hello, good morning. Good afternoon.
Afternoon, how is it?
I'm fine, thank you. This is Kalumba Kavedu, I'm the midwife. We have a term baby who was born through meconium. It was a Caesar. And this baby was born from a prime who had fetal distress. So we rushed into theater, delivered this baby, and we resuscitated this baby. And currently, the color is okay. The tone is somehow okay. The baby is improving, but the saturations are very low, about 90 somewhere there. So we've put the baby on CPAP, and our recommendation is that whilst we are transferring the baby to your unit, the baby is on CPAP. So I want you to prepare the room for this baby in the intensive care unit for continuation of care.
Okay, thank you so much for that update. We'll be ready for you in 5 minutes.
Thank you so much. Am I talking? Whom am I talking to?
You're talking to Netflix.
All right, thank you so much, Mr. Matthews.
Okay, so the neonatal unit is ready to take up this baby in 5 minutes.
Yeah, we'll
To
prepare the
continue with the
transport
CPAP.
incubator
So
for CPAP.
great. So it's ready. So Humphrey, you were taking notes.
Yes.
Please just run us through of what you have documented so that we know that everything has been documented before the transfer.
Okay, so we were, I was taking notes while we were doing the resuscitation here. We started at 3:41 p.m. SAS, that was the time which was needed, and we overall everything, the whole thing that we were doing here, we took about 5 minutes up until we had the baby. So what we did was that where we took a bit of some time, it was where we took a bit of some time, it was we were trying to have the baby receive the air. Okay, so at that point, we managed to go through. That was like 60 seconds plus, like a minute plus. So at least we were able to give the air that the baby needed. And the other thing is that we had challenges with the chest compressions, of which we did the chest. We had challenges with the heart rate, but we managed to have the heart start beating by the help of the chest compressions that we initiated. And then furthermore, we had to add some drugs, which one of them, which is just the adrenaline, which was given at 0.6 mL. Yeah, then we had the heart rate pick up. it improved. That was, we took about 4 minutes or so plus, yeah, somewhere in there. Then the other thing that I took note of is that anyway, apart from all that we did, we had our CFA prepared and we commenced it early. Then we also managed to call NICU in advance, informing them about what we had and what they should expect, and they should also prepare the same CFA for the baby. And also, I also noted that the mother was cancelled, yeah, which was very good. Then the other thing also, we had to call NICU to inform them about the same situation that we had here. Then the temperatures here, at least we managed to keep them within the normal range in the semi, yeah, at 6.5 to 6.6 at least. Yeah. Then the heart rate is at 90 to 93. I mean, the SpO2 is 90 to 93. Then the heart rate was above 120. So the whole research took us about 5 minutes. I think we were within 10 looking at the situation that we had. We managed to put everything closer to us so that we can be able to succeed. Yes. And I'm happy that from what I saw from the mother, within the shortest period of time, the mother was talked to, and at least they elevated the anxiety that she had. So, yeah, thank you very much.
Okay, thank you.
Anything?
So we're done with the baby. The baby has already been taken to the neonatal unit. So team, we need a debrief again. Did we miss any step? Is there any step that we need or do we need to practice more? Talking about equipment, did we have everything ready? Is there any problem that we encountered during the resuscitation?
I think to start with, one challenge that I saw is that I think I was our team leader. You were there, yes, we were hands-on there and busy thinking about what we should do next. The point when you requested for the adrenaline to be given, I think Matthew did not hear you clearly. So he had to come back again and talk to you. I think so next time you need to be more louder. Yeah, so that one can just speak, because this is an emergency.
Okay.
Yeah, I think next time I know
We'll speak louder.
we'll speak loud.
Thank you. Noted, yes. Any other challenge, Kevin?
We did well. And I think we did 2 cycles of chest compression before giving adrenaline, because there was that miscommunication, like my Chunka said. They didn't hear well the closed loop communication, which was a breakdown, there was some breakdown there. So we did 2 chest compressions before giving adrenaline.
Yeah.
We should actually give the first chest compression and then give adrenaline, then repeat the chest.
Most definitely. So we couldn't actually stop the chest compressions while waiting for that because we needed to continue.
Because once we told we stop, then we would deteriorate.
Okay, so Matthews?
I think we're on point. You say at least the fact that you are communicating as a team lead, that there must be that communication with the people that are working with, and then the division of labor, like Humphrey, he knew the role he was playing in this case. Mr. Kaberu also knew the role actually was playing the resuscitation. So as a leader, you should at least be there and then so that you communicate to avoid make some of the mistakes. Except that they are not loud enough when giving the instructions. Yeah, okay.
Okay, that has been noted. For me, I think you did very well. Thank you very much, team. You did all your roles on point and correctly. The documentation was good. And I think for everything that we did, we've documented. You were there to actually do chest compressions. And I think we did very well. There was no interruption there. And you got the veins, the UVC in quickly, and you were able to give all the drugs that needed, and you checked the blood sugar. That was perfect. And I think we've already taken the baby to the neonatal unit. Well done, team. So let's just clear let's just clear this table and then prepare for the next resuscitation in case we have another one.
Okay.
Okay, over to you, sir.
Thank you so much, NICU team. And you'll agree with me, Network, that this has been a brilliant presentation. And let's congratulate them for the first successful neonatal resuscitation on our REMCAM echo session. So without wasting much of our time, we're already behind time. I'll ask the team of experts to come through and give their comments. The floor is open. If there are any burning questions from the network, I'll ask people by show of hands to raise their hands and ask those questions. The team of experts is available to attend to those questions. If there's no question, I'll ask the team of experts, starting with Dr. Kapembwa, who's been very helpful answering all the questions that came through in the chat box. Thank you so much, Dr. Kapembwa. We really value your support. I'll ask you to give your comments if there are any. Dr. Sakala, are you on the call? Okay, Dr. Kapembwa is unable to speak at the moment. Dr. Kapembwa, you can go ahead. I think you've been given access. You can unmute yourself. Before she comes through, Dr. Sakala, if you're on the call, kindly unmute yourself and give any comments. I also asked Dr. Chege if she's on the call to give her comments with regards to today's session. Any points to clarify? Any addition?
Good afternoon, Dr. Siloka.
Good afternoon, thank you. Please go ahead, Doc.
Okay, thank you very much. So I want to congratulate the team for the job well done, for the teamwork that they've demonstrated throughout this presentation. And like I earlier said, this algorithm is created by the health workers, including, most importantly, the NICU team, because we realized that there were so many algorithms that people would come here and teach. We had, helping babies breathe. We had the NRP from the US. We had the UK algorithm. So this is meant for us, for our setting, because we understand that not everyone will have a pulse oximeter. So we won't be able to check their heart rate. So that's why we go by color tone and breathing, because even though we say dark babies and the colors are unreliable, it still helps us actually manage these babies. So I think that the team has actually demonstrated very well what the results of teamwork are. There were a number of questions asked in the chat box, and I think the only one that wasn't addressed was one where somebody was asking when to use the normal saline. So you don't use normal saline routinely, but if the baby's color is not improving, and especially if there was any history of having had a bleed, like in mothers who may have had APH, we then assume that the baby is volume depleted, and then we give a bolus of saline. Or we are doing everything we can. We've given our dextrose, we've done our chest compressions, and we've given adrenaline. This baby is still not improving. There's room to give a dose of normal saline. But it shouldn't be repeated doses, because these are actually going to be detrimental to the neonate. I think the rest of the questions I've answered. Thank you very much, team, and thank you, Dr. Siloka, for the excellent moderation.
Thank you so much, Dr. Kapembwa. We really appreciate, and we appreciate your support. Dr. Chege, if you're on the line, kindly give us your comments. Okay, I'll ask Dr. Nabuliato to give her comments just before we wrap up our session.
Thank you, Dr. Siloka. So I really don't have much to say. I think the teamwork was really good. Just a reminder that neonatal resuscitation is not a one-man job, but it needs to be done by a team. Whether you're an expert or not, but everybody needs to push in their effort to make the baby survive. And there shouldn't be anyone trying to do this job alone. As you can see, it's a teacher's job. Everybody has to play a role in this, and you cannot wash your hands out of it. So with the team, I think it's just kudos, because it was really great to have this demonstration. I hope everybody learned something and picked something from neonatal resuscitation. Thank you.
Thank you so much, Dr. Nabuliato. Dr. Sakala, I think Dr. Sakala is unable to speak, but he sent something in the chat box. We'll just read his comment. Dr. Sakala says, thank you, NICU team and everyone for attending and participating in this meeting. Always remember, have a team leader and don't panic. Very, very important message from Dr. Sakala there. We really appreciate Dr. Sakala for your support. If Dr. Chege is still on the call, I'll ask her to give her comments. I think Dr. Chege dropped out. She had dropped off along the, as the session was going on. So I think from the Remcan Echo Hub, it's me, Dr. Siloka, who has been your facilitator in this session. And we want to thank you, the NICU team, led by Sister Jean, and all the panelists that came through, the team of experts. Special thanks to Dr. Kapembwa for coming through and helping us to handle all those questions that were coming in the chat box, and as well as adding a spice to this session. We really appreciate also Dr. Sakala's support, Dr. Chege, Dr. Nabuliato, and the IT team for making this possible. So team, until we meet next time, it's bye for now. Thank you so much.
Good afternoon, Dr. Siloka.
Good afternoon, thank you. Just before we leave, please.
Also, just before we leave, team, this is Charity Bwadia from USID FHM. And just on behalf of our Ramcan National Echo Coordinator, Dr. Luvansa, just to thank everyone for joining and for the great work the NICU team have actually put in place. And to remind the team that our next session will be in the next 2 weeks, after 2 weeks from now, and we'll be looking at the essential newborn care. Please encourage those that have not yet registered to do so. And those that need support will soon, I think we'll also encourage all the provincial IT expert teams to actually help with the registration. Thank you.
Thank you so much, Madam Charity. We really appreciate. So team, in 2 weeks' time, we'll have another exciting session. Be sure to join us. For now, it's bye-bye, and thank you. God bless.